Hello, everybody. It's Andy Shaw here. I'm an intensivist anesthesiologist at the Cleveland Clinic in Ohio. And I'd like to thank the IARS for asking me to talk for the next 15 minutes or so about fluids for resuscitation. Here are my disclosures for 2022. I do have some financial relationships, but none of them are relevant to today's talk. We're going to squeeze 100 years worth of data into about 15 minutes. We're going to talk about some old studies, some new studies. We're going to try and put them all together, and we will arrive at a reasonable plan, at least a plan that I think is reasonable for busy clinicians as they have to make a decision at the bedside about which fluid to administer. As you know, not all IV fluids are equal. Depending on the electrolyte composition, whether it's more or less like plasma, they will cause a hyperchloremic acidosis if the fluid in question has a strong ion difference associated with it, such as saline, seen here on this graph on the right-hand side of the screen. On the lower left of the graph, the patients in red have been treated with normal saline, which has a big strong ion difference, and that leads to generation of a hyperchloremic acidosis. You don't see that if you administer buffered or balanced fluid to patients. Here is work from Dilip Lobo's group in Nottingham. They administered 2 liters of crystalloid to volunteers, Nottingham medical students, and measured the changes that each type of fluid induced in the kidney in terms of renal cortical tissue blood flow and also total organ renal flow measured in terms of flow in the renal artery. This was a crossover trial, a theme which is important in fluid research, as you'll see later on. And they demonstrated that in patients given saline, there was an immediate reduction in both total organ and cortical blood flow, statistically significant by about 30 minutes afterwards. So if that happens in healthy volunteer kidneys, one shudders to think what happens in the kidneys of older patients, particularly those with some severe comorbid disease. We published in 2012 in the surgical literature a paper highlighting an association between adverse events, the composite of all of these different types of complications you can see on the left of the screen, and administration of resuscitation fluid. Patients who were treated with 0.9% saline only had a statistically significantly higher incidence of the composite outcome. And in fact, that was also the case for interventions that caregivers used to work up acidosis problems. So more buffer was administered, more blood transfusions were administered, more arterial blood gas analyses performed, lactate levels, even dialysis was higher in patients treated, surgical patients treated with 0.9% saline. We then went on to demonstrate an association in septic patients in the intensive care units in hospitals, predominantly medical ICUs. This graph shows the percentage of fluid administered that is of buffered variety, and you can see as the percentage increases across the slide from left to right, so the associated mortality reduces. So in a nutshell, the more fluid you give a patient that is buffered, the lower the mortality. The corollary, of course, is the more saline you give someone also, the higher the mortality, at least in the observational literature. Here is an interventional trial. This is a before and after trial conducted in Australia, in which the authors removed chloride-rich fluids from their ICU. And you can see that in the period after the fluid was removed in 2009, the incidence of moderate or severe, or stage 2 or 3 AKI, was much lower in the after the chloride-rich fluid period, in the period after which chloride-rich fluids were removed as opposed to beforehand. So take chloride-rich fluid out of the ICU, incidence of severe and moderate to severe kidney injury reduces. Here's a summary of some of the literature suggesting that saline is bad for you. I won't follow this with a slide of the literature that suggests that saline is good for you, because until last year, there isn't any. And I think that's indicative of an underlying trend, if you will. Here is data from the SALT trial. When I was at Vanderbilt a few years ago, we were designing a large pragmatic interventional trial. And this was a pilot trial we did to see whether or not, one, we would be able to conduct such a trial, and two, to get a sense of the incidence of the primary outcome variable, which was MAKE30, or major adverse kidney events, which is death, new dialysis, and persistent renal dysfunction at 30 days. And you can see, although the overall p-value is not significant in this 1,000-patient pilot trial, as you start to give more and more fluids, so you start to see a much higher incidence of that kidney adverse event composite. And that emboldened us to go on to do SMART and SALT ED, which were a pair of studies we published in the New England Journal at the end of February in 2018. One in the intensive care unit population, so that's SMART, seen on the left-hand side of this slide, where we randomized, or included, should I say, a little over 15,000 patients. And then SALT ED, which is the non-intensive care population, patients who were admitted to the hospital but came through the emergency room and didn't go to the ICU, another 13,500 patients. The primary outcome variable in both of these studies was MAKE30. In the intensive care population, statistically significantly higher in patients given saline. And just to remind you the design of these trials, if you were admitted to an ICU, all of the fluid being used in that ICU for that month was either saline or balanced crystalloid. And that was the randomization, the initial allocation of the unit to the fluid. And thereafter, every month, there was a crossover. So all of the fluid these patients received was either saline or balanced fluid. And that is what allowed us to achieve separation of exposure, which is missing in some of the other trials. The composite here is driven by death. That's important. In the SALT ED trial, which is the ER patients who did not make it into the ICU, the composite is also statistically significantly higher in patients treated with saline, but this time it's driven by persistent renal dysfunction. These patients are also less sick, and so the incidence of the overall composite MAKE30 is also lower. So in both of these trials, MAKE30 was significantly higher in patients treated with saline. Death, new dialysis, persistent renal dysfunction. The composite's driven in the intensive care population by mortality, and in the less critically ill patient population driven by worsened renal function. We also looked at a subgroup of patients in SMART and SALT ED who were septic, and we see that the earlier the treatment with buffered fluid begins, the more pronounced the separation in terms of hospital death. So septic patients treated with saline, higher mortality than patients treated with buffered fluid. And we think that's pretty compelling evidence. There's almost 30,000 patients in these trials. All of the fluid they got was allocated to one or the other. And we think that more than effectively compensates for the fact that this is not patient-level randomization. However, there are a couple of patient-level randomization trials available. BASICS, which was published in JAMA last year, and PLUS, published a few weeks ago in the NEJM by Simon Finfer et al. So let's talk about these two trials because they are clouding the issue, at least in my opinion, a little bit. And I want to just point out a couple of features of these trials, and then we'll look at a systematic review, which was published on the same day, which brings all of this into perspective. So BASICS, 10,500 ICU patients in 75 units in Brazil, randomized to get either plasma-like, which is a buffered crystalloid solution, or 0.9% saline. You had to be reasonably unwell, you had to be hypotensive, you had to have some evidence of organ dysfunction to get into BASICS, and the primary outcome was 90-day survival. Baseline characteristics, as you would imagine, in an RCT were the same. They didn't get very much fluid, though, for a resuscitation trial, only 4 liters over the first study week, which isn't really very much, in my opinion. And I think that's one of the reasons that led to them finding the result that they did, which was absolutely no difference whatsoever in 90-day mortality for all comers. But, and here's the first evidence that saline is actually better for some patients, traumatic brain injury patients did better when treated with saline than balanced solution, almost certainly driven not by the chloride concentration, but the tonicity differences in these two crystalloid preparations. PLUS is a 5,000 patient trial published in the NEJM, as I said a few weeks ago, by Simon Finfer and his colleagues in 53 ICUs in Australia and New Zealand. Similar inclusion criteria, everybody over 18 who was expected to be in the ICU for at least 3 days, needing fluid resuscitation. Again, primary outcome variable, 90-day mortality, with some important subgroup analyses pre-specified, and you can see those on the slide here. No difference in survival, no difference in serum creatinine levels either. Again, not really very much fluid given on study here, and I have emphasizing the phrase on study for reasons we'll see in a minute. So 4 liters over 6 days, I don't think most of us would think counts as fluid resuscitation. But again, no difference in outcome, either pre-specified subgroups or overall. So why is that? Why is there such a stark difference between Smart Salt ED and all of the observational literature and these two individual patient level randomized trials? Well, in these latest trials, because they were not primarily pragmatic design, there was a substantial crossover in terms of exposure group allocation. A lot of the other type of fluid was given in each intervention group. That's the first problem. Second problem is they didn't really give a lot of fluid. And the reason for that is a lot of the patients, for example, in basics, 48% of them came from the OR, had already been given a lot of fluid. And so the need for resuscitation was less so. And we know from the ANZICS group actually, that around the world, there's been a big shift towards use of buffered fluid because of the previous decade's worth of observational work. And I think, and the last thing about basics and plus is there isn't any data presented in at least I don't think there was in large fluid volume administration patients. So I think these two trials really underscore the importance of when you're trying to capture interventions in a complex environment like the intensive care unit, you have to set trials up so you capture all of the intervention and try and minimize the amount of contamination from the other side as is as is feasible as much as you can. Bringing this all together, the same day that they published the PLUS trial, Naomi Hammond and colleagues, again from the ANZICS group, conducted a really elegant systematic review with a nice meta-analysis using a sort of a Bayesian approach. In other words, taking into account what we think we knew before. And they conclude that overall, there's a 90% probability that balanced electrolyte fluid reduces mortality in ICU patients. That's a pretty good bet if you're a betting person and you've got to make a decision at the bedside, with the notable exception of traumatic brain injury, of course, in which we know now that 0.9% saline is a better choice. So here's Andy's EBM guide to IV fluids in 2020. Is there a head injury? If there is, use saline. If there isn't, use a balanced or a buffered, depending on your favorite term, electrolyte fluid. So to conclude and wrap this up, we've romped through over 100 years worth of data in a little over 15 minutes. However, we know a lot about this intervention. There are more RCT data in this space than any other ICU intervention I'm aware of. Yes, it's true, the treatment effect is small, the hazard of chloride is small, but that's not the point. The point is the exposed population is enormous. All hospital inpatients receive IV fluid. So if there's even a tiny difference, it's important to know about it. The Hammond meta-analysis, which adds all of this information together and synthesizes it into a result that's accessible for us as caregivers, suggests that there's a 90% chance that a buffered choice is the smart one, except for in traumatic brain injury, when you're better off choosing saline. And so to conclude, I would finish up by saying that yes, I think BEF is indeed your BFF, and I would welcome any discussion, any correspondence about this. My email address is shaw8@ccf.org. Thank you very much for listening, and please enjoy the rest of IARS.
Hi there. Thank you for this opportunity. Today, I'll be talking to you all about vasopressors instead of fluids. These are some of my financial disclosures and potential conflicts of interest. My presentation does not include discussion of off-label or investigational use devices. So when we talk about sepsis and septic shock management, it's a combination of a lot of things, from antibiotic source control, sepsis markers, appropriate fluids, vasopressors and hemodynamics, adjuncts such as steroids and glycemic control. And today our focus is going to be around vasopressors and fluids. So the guidelines for management of sepsis and septic shock are the very familiar surviving sepsis guidelines. We're all very familiar with the phases here. Initial volume resuscitation, you can't get a MAP of 65 and you're still not able to get a MAP of 65, then start norepinephrine and then escalate onward to vasopressin, epinephrine, and dobutamine. This reference is from Andrew Rhodes in 2017, but this part of the guidelines has not really changed on the newer edition of the guidelines as well. So the broad concept is initially fill the tank, and then you're not able to maintain a MAP of 65. Then you can either decrease the capacity of tank by using vasopressors or increase the pump speed by using inotropes such as dobutamine. The important issue is that filling the tank is a problem. That's the traditional concept of fluids first, followed by vasopressors. Because while we're filling the tank, we can fill it up too slowly, we can do too much, or we can do too little in terms of fluids and the empiric handling of fluids. What happens when the tank doesn't get filled up quickly enough, or it gets inappropriately filled up with fluids, is that there is hypotension, and we're all fighting hypotension. And here's the problem with hypotension: the longer a patient stays hypotensive, the more issues with myocardial injury, mortality, and so on and so forth. Here we did work where we identified that with every 1 hour of increasing exposure to hypotension in ICU patients, there was a significant increase in organ system failure. Burden of hypotension, like I said, in the ICU is significant. This is data from the MIMIC data set that shows that despite knowing surviving sepsis guidelines, a large chunk of our patients remain hypotensive for prolonged periods of time in the intensive care unit. And when they remain hypotensive, there is a progressive increase in mortality at different thresholds of blood pressure. True thresholds of hypotension in the ICU can be varied. Again, once you get below a MAP of 65, the predicted marginal probability of poor outcomes increases with every single time-weighted average less than a MAP of 65. So let me come back to the surviving sepsis, the latest edition of the surviving sepsis guidelines. So what do they say about fluids and pressors? So the level of recommendation is a weak recommendation with low quality evidence for at least 30 cc's per kilo, very familiar, within the first 3 hours of resuscitation. And then they add now the suggestion of using dynamic measures to guide fluid resuscitation over just physical exam or static measures alone. And then they talk about the various dynamic measures and also biomarker guided resuscitation. And finally, they talk about capillary refill time, very importantly, as an adjunct to other measures of perfusion. So still not very clear on fluids first versus pressors first in the latest edition. And in fact, when talking about how much fluids, Laura Evans and colleagues with the latest edition of the guidelines say that there's insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies in the first 24 hours of resuscitation in patients with sepsis and septic shock who have signs of hypoperfusion and volume depletion after initial resuscitation. So still insufficient evidence to make broad-based guidelines based on restrictive versus liberal fluid strategies, or vasopressors first or fluids first. In fact, when they talked about research priorities in adult patients, the Surviving Sepsis Guidelines Committee convened a group to author this paper, and they did talk about this being a research priority for the Surviving Sepsis group. And namely, the research priority was, do early vasopressors limit the amount of fluid? So if we start pressors early, decrease the capacity of the tank, will this limit the amount of fluids we need to reach the same hemodynamic target? If so, what is the appropriate ratio of fluids and pressors? And is there a benefit for a polytherapeutic, a synergistic approach to pressors and fluids, and so on and so forth? So certainly high priority for the Surviving Sepsis group to find some answers regarding fluids versus pressors. There has been some research, though. This is some prospective work that was performed that actually did show that very early vasopressors that was initiated before the next hour of the first resuscitative fluid load. So when norepinephrine was started before the next hour of the first initiation of the fluid load, that very early vasopressor led to a significant improvement in survival probability compared to delayed or standard vasopressor management in patients with septic shock. Volume chasers was an important study that was done by the SCCM group, and actually gave us quite a lot of ideas, but still left some questions unanswered. So what volume chasers answered was that vasopressor dosing intensity within the first 6 hours was associated with an increased odds of 30-day hospital mortality. For the first 24-hour period, every 10 mics per minute of an increase in vasopressor dosing intensity was associated with an increased risk of 30-day mortality. And importantly, they looked at an early high versus late low vasopressor dosing strategy, or an early low versus late high or sustained high vasopressor dosing strategy. So what they found was if you start vasopressors high initially and then down titrate them, that is associated with an improved survival. So really, initially loading vasopressors seems to be more important than initially starting low and then increasing, or just giving a sustained chronic dose of vasopressors in patients with septic shock. And clearly there was an attempt to answer a lot of other questions in terms of mortality at 30 days and total fluid volume in combination with different norepinephrine equivalents. But they did find that increasing vasopressor dosing intensity during the first 24 hours after septic shock was associated with increased mortality. And this association varied with the amount of early fluid administration and the timing of vasopressor titration. So clearly in line with the whole concept of more personal, low fluids, high pressors initially. Although the key trial was the NHLBI Petrol Network trial called Clover's crystalloid liberal or vasopressor early resuscitation and sepsis. And this trial has been recently stopped because of futility and no significant difference in 90-day mortality rates, safety concerns, no safety concerns, and really we are yet to see a publication from this, but I'm sure the data that is published, even though the trial has been stopped because of futility, will allow us to better answer questions on restrictive fluids, vasopressors first versus the other way around. Vasopressors early in general do help, and we look at norepinephrine vasopressin. Early vasopressin does improve outcomes as early as 10 mics per minute of norepinephrine. The later you delay vasopressin, outcomes worsen. And the important part is we do want to start vasopressors early, but the counter argument is that we are not sure whether starting vasopressors early and getting a good blood pressure does really improve microcirculation at the tissue level. And clearly, we still don't have those answers yet. We don't think there is a correlation or a close coherence between micro and macro circulation in septic shock. So just because you have a good blood pressure does not mean that your tissues are perfusing well. This is a prime example of that. You know, on the left side is a slide, you know, a normal healthy patient, and on the right side is a slide where a patient has been exposed to lots and lots of pressors. Both patients are at same blood pressure, but clearly there's lots and lots of tissue edema and sluggish flow when lots of pressors have gone in to maintain the same blood pressure. So there is a problem. The other problem is that we don't always monitor cardiac output along with blood pressure, and we don't always look at SVR. So we want them to be concordant, that you increase afterload and you increase afterload here at the bottom here, SVR goes up, cardiac output stays stable, and MAP goes up. That's the appropriate response to an afterload increasing agent. But a lot of patients, cardiac output will actually start drifting down as you increase the SVR. You do manage to get a MAP increase, but really flow is being compromised despite increasing SVR. And that's a problem. We've also seen, at least in the intraoperative world, that, you know, overexposure to vasopressors just for the cost of maintaining a blood pressure does not necessarily lead to good outcomes. In fact, you know, strong association with acute kidney injury after being exposed to intraoperative phenylephrine unnecessarily. So we recommend a more synergistic model while you handle vasopressors, you know, going from the adrenal medulla to the posterior pituitary and also the renin-angiotensin cascade. And furthermore, we do highly recommend a biomarker guided approach. There's been lots and lots of literature that has looked at renin as a marker of tissue perfusion and prognosis, and how it is actually better than lactate when we look at it as a marker of prognosis. And furthermore, there is research in the pipeline that really shows that biomarker guided resuscitation, when doing an early vasopressor strategy, would be the way to proceed. Finally, going back to volume chasers, this was a one of the sub studies there that really showed that instead of just doing empirical management of shock, which is everyone gets 3 liters of fluid, everyone gets some same sort of treatment, when treatment was based on physiological assessments that included ultrasound, CVP, PAOP, SVV, PPV, and so on, there was a significant increase in patients who got early vasopressors. There was no real big difference in the amount of fluids received in each arm, and there was no real big difference in cumulative fluids received, at least in the initial part of shock management. But overall, again, there was a tendency that patients with actual physiological personalized assessments with some of these dynamic measures do achieve a vasopressors up front, less cumulative fluid kind of outcome. That is really where we want to take all of this. We want to take all of this to a more personalized medicine approach and go away from the one size fits all approach. And again, this is our simplified approach of management of hemodynamics and sepsis. This is no rocket science, but really, again, if you look at the middle part here, I do emphasize on rational combination vasopressor therapy that should be, all the way up front, that starts with norepinephrine all the way in an early shock state itself. And overall, the outcome should still focus on catecholamine sparing strategies rather than just, again, if you want to do vasopressors first, it cannot just be all catecholamines all the time. So to summarize very quickly, the approach should be early multimodal vasopressor and fluid therapy. So the polytherapeutic approach that the SSG group recommends. Don't wait for a failure of either fluids or vasopressors. Initiate them together. More reliance in development of targeted biomarkers, and do not forget adjuncts as you resuscitate your patients. Thank you so much for your time today.
I want to thank the IARS organizers and Dr. Pearl for the opportunity to present at this session. I have no financial conflicts of interest to disclose and will not discuss off-label or investigational use of drugs. And now I'm going to shift gears a bit towards the basic translational science end of the spectrum and focus on the microvascular dysfunction related to endothelial activation and dysregulation in sepsis. I'll provide some general background on endothelial function and dysfunction in sepsis, focus on endothelial cells as immune cells and potential targets for sepsis-based therapies, and talk about some of the difficulties with studying the microvascular endothelium in sepsis. I will start by saying that our understanding of sepsis pathophysiology at the cellular and organ level is limited. Human studies tend to focus on circulating mediators and leukocytes. This approach has led to huge insights into the immune system in sepsis and is practical because blood is easily accessible and can be repeatedly sampled over time. But it has led to somewhat of a leukocentric focus, and there are fundamental gaps in knowledge about how other cells, including leukocytes in tissues, neurons, epithelial cells, and the star of this talk, endothelial cells, contribute to sepsis pathophysiology. The human body contains more than 1 trillion endothelial cells. Due to their widespread distribution throughout all organs and tissues, endothelial cells are uniquely situated to sense and respond to invading pathogens and injury. Under optimal conditions, endothelial cells promote beneficial immune responses, fine-tune coagulation pathways, and regulate the vascular barrier. Under pathologic conditions, there may be excessive or generalized endothelial activation, dysregulation of coagulation pathways, and endothelial barrier dysfunction leading to vascular leak. The resultant tissue edema, microvascular thrombosis, and leukocyte activation in organs and systemically are believed to contribute to sepsis-induced shock and organ failure. This slide is a rough depiction of what I call the triad of endothelial perturbations in sepsis. Because of the central role of the endothelium in the host response to sepsis, it has long been proposed as a target for sepsis-directed therapies. These next 3 slides provide some more detail about the triad of endothelial perturbations in sepsis. I think of endothelial cells as non-classical immune cells. They express innate immune receptors, including the toll-like receptors. They express receptors for cytokines such as IL-1 beta and TNF. And these receptors signal through classical intracellular inflammatory pathways, and their activation leads to the production of inflammatory cytokines and chemokines, as well as to increase inducible nitric oxide synthase expression, the generation of nitric oxide, superoxide anion, hydrogen peroxide, and peroxynitrite, all of which can potentiate endothelial dysfunction. Endothelial cells help to maintain the balance of the coagulation pathways. Vascular injury induces the upregulation of tissue factor, which initiates the coagulation cascade. Fine-tuned counter-regulatory mechanisms limit the extent of coagulation and promote fibrinolysis. Sepsis induces a shift of the endothelial cell profile toward a procoagulant and antifibrinolytic phenotype. Endothelial cells and recruited leukocytes express high levels of tissue factor, and there is glycocalyx destruction and the release of microparticles, which amplify the coagulation cascade. This is compounded by downregulated production of anticoagulants, increased production of PI1, and reduced production of activated protein C. It is also exacerbated by the release of von Willebrand factor by activated endothelial cells. The resultant microvascular thrombosis is worsened by deposition of neutrophil extracellular traps and activated platelets. Endothelial cells perform critical functions in maintaining the vascular barrier. During homeostasis, the glycocalyx maintains local selective permeability. Sepsis dysregulates the vascular barrier to fluids, proteins, and cells. It injures the glycocalyx and impairs the functionality of adherens junctions, which leads to capillary leak. Furthermore, localized endothelial cell production of chemokines and upregulated endothelial adhesion molecule expression enhances leukocyte recruitment and transendothelial migration into inflamed tissue, thereby exacerbating the injury. With this background on endothelial cells functions, I'll show some data that we've generated over the years on endothelial cell activation and dysfunction. I mentioned before that endothelial cells express the innate immune receptors. In this study, we documented the expression of multiple toll-like receptors by human endothelial cells from vascular beds, different vascular beds, including HUVEC and microvascular endothelial cells from coronary arteries, the brain, liver, and lungs. My lab has a longstanding interest in the role of toll-like receptor 2 in sepsis and in immune function in general. Toll-like receptor 2 recognizes bacterial lipoproteins that are expressed by gram-negative and gram-positive bacteria. These bacterial lipoproteins are shed into human serum and into the blood of septic rodents, and we found induce systemic and organ inflammation, coagulopathy, and lung dysfunction in mice. In these experiments, we treated human endothelial cells with several toll-like receptor 2 agonists, including PAL and MLP, which are naturally occurring TLR2 agonists in the bacterial lipoproteins and gram-negative bacteria, and PAM3-cis, which is a synthetic like protein, TLR2 agonist. We found that TLR2 agonists upregulated IL-6, IL-8, and other cytokine production by both HUVEC and human lung microvascular endothelial cells. On the right is a neutrophil adhesion assay. We treated HUVEC with PAL or medium and then washed those away, and then assessed the binding of fluorescence-labeled neutrophils to the activated monolayer, and found that there was increased binding of the fluorescence-labeled neutrophils to the monolayers that had been pretreated with PAL. We've also found that the activation of endothelial toll-like receptor 2 leads to a pattern that is consistent with sepsis-induced coagulopathy. In the top panel, we treated lung microvascular endothelial cells with PAM3 cis, which we found upregulated surface expression of tissue factor, the secretion of PI1, and the secretion of PI1 into the supernatants, and downregulated TPA secretion into the supernatants. In the bottom panel, wild-type and TLR2 knockout mice were treated intravenously with PAM3 cis, and we found that PAM3 cis upregulated PI1 levels in the blood of wild-type, but not TLR2 mice. We used two in vitro methods to study microvascular endothelial permeability: transwells, which measure the movement of a tracer across an endothelial monolayer, and electric cell substrate impedance sensing, or ESIS, which measures the impedance to the flow of electrical current across a cell monolayer. In ESIS, a decrease in resistance is consistent with increased permeability. ESIS has an advantage of being a highest throughput system and the ability to measure transendothelial resistance repeatedly on the same monolayer over time. In this figure, we show that PAM3 cis increases, or rather decreases, transendothelial resistance, which is consistent with increased permeability. We've also branched out to look at all of the other toll-like receptor 2 or toll-like receptors in endothelial cells, and have sort of extensively mapped out intracellular endothelial, intracellular TLR signaling pathways. There are some issues that have come up as we get further into studying endothelial activation and dysfunction in sepsis. First, it's difficult to access endothelial cells and or assess their responses in situ in real time in vivo. This is especially true in humans, but it is also true in mice. Second, and as I'll show you momentarily, there are substantial differences in the sensitivity of human and mouse endothelial cells to LPS and bacterial. Namely, mouse endothelial cells are substantially less sensitive than human endothelial cells. And third, the responses of human microvascular endothelial cells from different donors to LPS varies widely. And this was nicely shown in a paper that Jeremy Joffrey recently published in Critical Care Medicine on catecholamines, and I'll describe a little bit of that paper in a moment. This is a slide to show the differences in the sensitivity of human and mouse endothelial cells to LPS and heat-killed E. coli. And we measured transendothelial resistance, and we found that human microvascular endothelial cells were permeabilized by both LPS and heat-killed E. coli, but it was very difficult to cause increases in mouse microvascular endothelial permeability. In this final section, I'll touch on the potential for endothelial cells as targets for immunomodulation in sepsis. Immunomodulation is broadly defined as a change in the immune system that's caused by activation or suppression of immune function by intrinsic or extrinsic factors. This was a study that was conceived and done by Jeremy Joffrey, who spent nearly 4 years in my lab as a postdoc and recently returned to Paris, where he is an associate professor in critical care medicine and setting up his own independent research program. He tested the effects of catecholaminergic and non-catecholaminergic vasopressors on endothelial cell activation, or actually permeability, induced by LPS. He found that epinephrine and norepinephrine completely reversed LPS endothelial permeability. Furthermore, even if epinephrine was delivered long after the onset of LPS-induced permeability, it reversed the permeability. This is shown with statistical analysis. These are the area under the curves for LPS and epinephrine treated endothelial monolayers. He also found that norepinephrine and epinephrine reduce TNF-induced endothelial permeability. Notably, vasopressin, angiotensin II, and phenylephrine did not reduce LPS-induced permeability. So I hope that I've convinced you that endothelial cells have multiple roles in healthy and pathologic responses to sepsis. They express innate immune receptors, produce multiple inflammatory mediators. Their activation by inflammatory agonists promotes vascular leak and coagulopathy. Catecholamines reverse LPS-induced permeability of lung microvascular endothelial cells. And I didn't mention this, but they do so via beta-adrenergic receptors, and they do not affect production of cytokines. So I would venture to say that endothelial cells are immune cells. And I speculate that targeting specific endothelial cell responses in sepsis may reduce organ injury without negatively impacting leukocyte-mediated antimicrobial defenses. I'd like to briefly acknowledge the folks that have contributed to the various endothelial cell projects over the years, including the current members of my lab and past members, collaborators, and my funding sources. Notably, since this is the IARS meeting, I was extremely fortunate to receive funding from the IARS at a critical juncture in my research career, for which I am very grateful. Thank you.
So good afternoon. I'm Ron Pearl, a professor in the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University, and I had the honor of organizing this panel on sepsis and moderating this upcoming discussion. Sepsis is a major medical problem. A study by Rudd in Lancet 2020 estimated there are 49 million cases of sepsis worldwide, resulting in 11 million deaths, representing 1 out of every 5 global deaths. In the United States, sepsis affects almost 2 million adults each year and results in more than 250,000 deaths. Clearly understanding the underlying pathophysiological mechanisms involved in sepsis and septic shock and identifying optimal approaches to resuscitation are needed, and that's the concept behind this panel. We just heard presentations from 3 anesthesiologists who are leading the field in these areas. Let me very briefly introduce them, and then we have lots of time for questions. Andrew Shore is chair of the Department of Intensive Care and Resuscitation at Cleveland Clinic. He practices cardiac anesthesiology and critical care medicine. His research interests include the use of metabolomics, proteomics, and genomics for biomarker discovery in acute illness and injury, and observational and interventional trials of candidate interventions to prevent and treat adverse outcomes following surgery. Ashish Khanna is Associate Professor of Anesthesiology and Vice Chair for Research in the Department of Anesthesiology at Wake Forest School of Medicine. He's a member of the Wake Center for Biomedical Informatics, the Center for Healthcare Innovation, and the Wake Forest Hypertension and Vascular Research Cardiovascular Science Center. He's the Director for Perioperative Outcomes and Informatics Collaborative, a center of excellence for clinical trials across specialties. Judith Hellman is Professor and Vice Chair for Research in the Department of Anesthesia and Perioperative Care at UCSF. She's a critical care physician scientist doing basic translational research on sepsis and injury. Her research focuses on innate immune signaling, endothelial inflammatory signaling and dysfunction, and immunomodulation by the endocannabinoid and endophenylloid systems in sepsis and injury. So let's go on to questions. Please, if you have questions, put them in the chat. And we'll go ahead and start off because I have some questions for our speakers, starting off with Dr. Shore. Most of the studies having to do with balanced versus unbalanced solutions in the ICU have looked at all critically ill patients, medical and surgical. As we think about sepsis and septic shock, do you think there's a difference between the application there versus general ICU patients?
Thanks for the question, Ron. Good afternoon, everybody. Pity we're not in Hawaii, but I guess we'll make do. So is there a difference in the response of different types of patients to the type of fluid used, particularly sepsis? I think overall, no. What's different about sepsis is the volumes given are often much higher. There is quite convincing subgroup data from most of the trials that there is a signal in septic patients, especially when the exposure dose, if you will, goes up. So I think the decision to which fluid to use is still the same. What I would do with a head injured septic patient is a difficult question. I don't quite know. I'd probably try and limit the amount because the volume is probably more effective than the type there. But I think overall the decision, given the new data published in the last 18 to 24 months, is fairly straightforward now. I think you want to reach for a balanced or a buffered fluid first, and then be very careful about the amount that you give over the next few days. And I think I guess this isn't really a total dose of fluid question or talk, but I do think that's equally important.
And I think we'll be getting to a dose of fluid along those lines, Dr. Khanna. And you mentioned recommending that we should consider starting pressors early. Have you changed your approach to aggressiveness of fluid resuscitation with the use of vasopressors?
Yeah. Hi, Ron. Hi, everyone. This is a great question because often we see that what we do in research doesn't really translate to what we do in real life practice. What I have tried to do in my practice is to really not wait around while we give fluid. I think that part is the part that really hurts us in general. I have seen over the years where we start giving fluids and the patient's, sort of hypotensive, and we wait for hypotension to declare itself and set in before we officially declare that we need a pressor, and then we go ahead and try and, get a pressor, and that waste. So I have personally really pushed for, or it doesn't really matter if you haven't finished your 30 cc's per kilo, go ahead and start a pressor, maintain perfusion pressure while you're finishing the rest of your fluid load.
And how do you balance trying to use more fluid, less pressure versus more pressure, less fluid? How do you know how much, how do you get the right balance? Does that change over the course of the patient's stay?
Personally, again, I gave you some of the data with volume chasers. I still feel that we need some follow-up studies after the volume chasers group, said what they said. I do think that it is important to give as much pressure as is necessary to maintain a good blood pressure. It's a separate question what a good blood pressure in the ICU is, separate discussion. But I do think that if that needs a high pressure first and low pressure afterward kind of approach, initial high followed by later low, then so be it. And I do that. I don't shy away from that. I don't shy away from pushing pressors and then slowing fluids down as the pressors start taking effect.
Dr. Goldstein has a question here. Sometimes patients become hypotensive during colon or urologic surgery. I would think almost any surgery. Usually phenylephrine is the first vasopressor that anesthesiologists choose. Considering that sometimes these patients may be in the early phase of sepsis, should we be using norepinephrine, epinephrine, or some other drug rather than phenylephrine, which is more likely to be associated with endothelial permeability? And anyone who wants to answer that. You're muted, Judith.
Okay, I think I can take part of this question. And first of all, I do want to say that our study is obviously a very basic, translation, or I guess a translational study where we saw the permeability difference, but it is provocative, I think. I don't think it's unreasonable to, assume that with these types of surgeries, there is sort of a, bacterial or endotoxin or whatever it is, a toxin shower that may be occurring acutely that would increase permeability, cause vascular leak, et cetera, and that could contribute. So, I would say it wouldn't be unreasonable, except that, there may be issues with sort of policies surrounding where, IV access and sites of delivery that make it impractical to have norepinephrine be the first line of treatment in those contexts.
So I would say, go ahead, Ashish.
Yeah, I was going to very quickly follow up. I think I was really excited seeing Judith's data today on how epinephrine, norepinephrine affect LPS and permeability, and how vasopressin, phenylephrine, and angiotensin II actually don't. And I'll say that here is a situation where, as anesthesiologists in the non-cardiac surgical operating rooms, we've been very comfortable with phenylephrine because we feel it's a gentle pressor. We can give it peripherally, where we struggle with giving epi or norepi peripherally, even though there's data now that suggests that norepinephrine within limits is safe peripherally. So a little bit of that is the bias with the central access. The other issue is unnecessary phenylephrine, as I showed in my unpublished data, is not the way to go. So it's certainly not like you increase you give an afterload increasing agent for every kind of hypotension that happens intraoperatively is not the way to go. It does give us a blood pressure. It's not the way to go.
And Dr. Goldstein in the chat has noted that there are prior studies of no safety issues using norepinephrine infusions. There are actually multiple ones of those now. And I would say, looking at what I see the practice in the operating room where I am, it's pretty common for people to actually now be doing norepinephrine boluses rather than phenylephrine boluses. They are more consistently effective, and they likely help maintain cardiac output. And the real concern we obviously have for a pure vasoconstrictor is that we're going to have inadequate cardiac output. That was it. The other stuff you said. If people are not speaking, please try to mute. Dr. Hellman, you mentioned the concept of potentially having endothelial cells be targets for immunomodulatory therapies. Can you expand a bit on that?
Sure. First, I guess, as I have sort of implied in my presentation, endothelial cells, I think of them as immune cells. They express receptors and intracellular signaling systems, that are involved in immunity, produce inflammatory mediators, develop permeability and whatnot. And I think that the dysregulation that's triggered proximally by inflammation and injury leads to organ injury and failure. And it seems possible that targeting one or another of the specific branches of the intracellular signaling pathway, such as either cytokine production or permeability or coagulation disturbances, could reduce vascular leak and organ injury while still allowing sort of the necessary immune-related functions like cytokine production to continue. And also, we've observed signaling differences, although I mentioned that the intracellular signaling machinery has similarities in endothelial cells and leukocytes. We've also found differences, particularly in two of the ERKs, two of the MAP kinases, ERK1, 2, and they're almost playing opposite roles in inflammatory signaling and endothelial cells and leukocytes, which could be another potential way to preferentially target cells with sort of endothelial cell inflammatory activation without messing up leukocyte inflammatory activation.
Thank you. There's a question from Dr. Garcia about the initial fluid resuscitation in septic patients who have right ventricular dysfunction. Any of our panelists want to comment on that?
I can talk about the amount of fluid, and maybe Andy wants to talk about type of fluid or both. I guess from my perspective, if I do know the patient is coming in with RV dysfunction, then I would certainly support the right ventricle with some epinephrine right from the get-go if I can. And I would try to be very judicious with fluids. Problem is that most of us don't really know if there is RV dysfunction until we're like hours into sepsis resuscitation. And again, that takes me back to the point of doing better assessments for our patients as we plan our resuscitation. I don't know if Andy has that.
I'll make a comment or two about this, because I think this is a remarkably insightful question, because there are differences in the way the pulmonary circuit responds to both adrenoceptor agonists and also to the vasopressin type drugs. We know that vasopressin doesn't squeeze the pulmonary circulation as much, and that might be critical for protecting a moderately failing right ventricle. I don't think the type of fluid matters here. I think the amount really does. And I think the only way to do this is with, effectively ongoing real-time POCUS, point of care ultrasound at the bedside, to have a look at the right ventricle and see how it's performing. We use a lot of inhaled prostacyclin therapy, and even for patients who are not intubated, we use the Airvo high flow system to deliver that a little more reliably. So I think protecting systemic blood pressure and not increasing pulmonary artery pressure is the key here. So I would typically use, as I said, semi-real-time POCUS to monitor the right ventricle, an inhaled pulmonary vasodilator like prostacyclin or inhaled nitric, and then a vasopressor that relatively spares the pulmonary circuit. So in this situation for me, that's vasopressin. And if I needed something with a little more inotropy, probably add in some systemic milrinone.
I would agree with Dr. Shaw. We know that the right ventricle, when it's dilated, all that giving more fluid does is it dilates it more, decreases the function of the right ventricle, and compresses the left ventricle. So giving fluid in that setting is not of value. And the only way of knowing in that setting is with ultrasound, either POCUS, surface ultrasound, or sometimes even transesophageal. Echo CVP may give you some guidance to that, and inhaled vasodilators work well. In the septic patient, if you don't have blood pressure, drugs like milrinone initially make it worse. The concept of using a vasoconstrictor and vasopressin is the one that nowadays people would initially start with. Getting adequate blood pressure and then being able to add in a drug like milrinone or sometimes dobutamine would be a reasonable approach. Dr. Shaw, you talked a lot about the choice of crystalloid solution. Can you give us some comments on where you think albumin is now for resuscitation of the patient with septic shock?
Yeah, it's interesting. Poor old albumin, because it's expensive, no one wants to use it. But the reality is there are some data, admittedly observational, that do suggest there may be a benefit in its use. If albumin costs the same as saline, I think it would be used in almost everybody, because there's no doubt about it, you need less volume to get the same hemodynamic effect. In fact, I do know folks in Australia who add a bottle of 25% to a liter of buffered fluid, and there you have an almost perfect sort of resuscitation solution, except for they don't make that for sale here. So personally, I like albumin. There's nothing like a bottle of concentrated albumin to get a decent hemodynamic effect and not hit the in-out balance chart. So I think there is a place for albumin. It's a shame it costs so much because I do think there is a benefit. Whether it's worth the 5 to 6 fold increase in price, I'm not sure. But I'm personally an albumin fan, and I think it does reduce the total volume of fluid given, which, if the patient survives, has to come back out of the patient ultimately.
Dr. Connor, I work in medical ICU, surgical ICU, and cardiac ICU. In medical ICU, we basically never use a pulmonary artery catheter. In surgical ICU, sometimes. In the cardiac ICU, almost always. Do you think a PA catheter is of value when you're talking about the use of vasopressors and septic shock?
Yeah, I guess, we talked about the failing right ventricle here and knowing more about our patients. So I do think it is of value where there is clinical suspicion that there is something else going on rather than just a usual, I'd say garden variety patient that comes in with septic shock. So it's a relatively younger patient, no real comorbidities that comes in with septic shock. Then I'd say the PA catheter is probably overkill. But I think if there is a more complicated patient, there's suspicion for something else going on, then I think shying away from putting a PA catheter is, I don't think that's the right approach. And we should probably be putting in more PA catheters in those patients.
Thank you. And then this will be, I think, our last question. Dr. Hellman, we've just lived through 2 years of COVID-19, and COVID presents as ARDS, which we think of as an endothelial cyst injury, and often presents with septic shock as well. What are your thoughts about the role of the endothelium in the COVID septic shock patient and the possibility of targeting therapy to the endothelial cells for COVID?
Great question. So at the time at the moment, there's a lot of circumstantial evidence that endothelial cells do play important roles in COVID-19 disease, particularly in severe COVID. Certainly the radiographic features and autopsy studies that show virus actually inside of endothelial cells and very significant endothelial damage in the clinical course are consistent with some form of endotheliopathy. And then there's, kind of increasing data out there on elevated circulating endothelial biomarkers and damage markers and their correlation with outcomes of death and poor outcomes in COVID. But so far, there isn't that much in sort of the basic translational world and on endothelial dysfunction. We've just finished up a series of studies looking at endothelial infection and dysregulation by SARS-CoV-2, as well as the effects of sera from patients with COVID and non-COVID patients on endothelial functions. And that's kind of in the revision phase. So stay tuned for that. But the data there are consistent with some sort of direct endothelial involvement, I would say, in COVID. And as far as being a target for therapies, I think, kind of for the same reasons I mentioned earlier, that I do feel that potentially the endothelium could be targeted, but we still have to understand far more about how it's working and whether it is driving or more kind of in the bystander injury position.
Well, thank you. And I want to thank all the attendees for your attention and your questions, and our three panelists, Drs. Schur, Connor, and Hellman, for what I've certainly enjoyed as a session. Hope that it will be of value to all of you as you treat these patients with sepsis and septic shock. Thank you.
Thank you.
Thanks. Goodbye, everybody.
Thank you.